All right, everyone. Hi, I'm Jessie Tyma. I'm a surgeon and I'm really excited to join the Rhinebeck equine practice. I know that I'm a new face to all of you and I look forward to getting to know all of you, hopefully not on an emergency basis off the bat, but we'll be there if needed. I wanted to spend a few minutes just to give you a brief overview of my background and what brings me here to Rhinebeck Equine and here today with you all at this symposium. I grew up in Bucks County, Pennsylvania, so this dot right here. I grew up riding hunter jumpers. I love horses from a young age. I went on and did my undergraduate work at Amherst College and then vet school at Cornell. After Cornell, I was lucky enough to get an internship at Rhinebeck Equine, where I spent a year learning with the team here. That was from 2014 to 2015. So I may have met some of you in the intern role at that time. I went from Rhinebeck down to the University of Georgia for my surgery residency. And following my surgery residency, I joined a private practice very close to home. I moved to Hunterdon County, New Jersey, and I've been there for the past 3.5 years practicing large private practice referral center. In that time, I've gotten to work with both a large standardbred and thoroughbred breeding population and racing population. I've gotten to work with these animals from a really young age in the foals, working on septic joints and physes, a little bit older, managing their angular limb deformities, older yet, preparing them for sales, managing OCDs, onto their 2-year-old year, breezing and looking at some buck shins, and then some of our racehorse surgical problems as well, carpal slab fractures, sesamoid fractures, condylar fractures, and working with some of these horses, not only in their racing careers, but then also transitioning them to their next career following racing. It's been a really rewarding experience, and I look forward to bringing this experience forward to the Rhinebeck Equine team here. So back to what we're talking about today, joint ill and why this is important to all of you. This is both a debilitating and life-threatening disease to our foals. It can cause permanent joint and or growth plate damage, and it affects foals from birth, can affect them all the way up until weaning. So really a wide age range there. I'm going to spend a moment here to go over a little bit of anatomy to contextualize how and why this happens and why it's important. So a joint is going to be in between two bones here. Each end of the bone is covered with articular cartilage. That's that blue line here. And it's surrounded by a synovial environment. That synovial environment is the joint itself. The joint is lined by a synovial membrane. That's the red here on each side. And that is what produces the joint fluid that keeps the joint environment healthy. The growth plate is this line that sits here a little bit above the joint. There's one down here as well. Each bone has one. The epiphysis is the bone that sits in between the growth plate and the joint, and the metaphysis is the bone that sits further away from the joint from the growth plate. Overall, what is joint ill? The veterinary terminology here is septic synovitis or arthritis. Synovitis refers to septic or an infectious process in the synovial cavity, so the joint itself. Arthritis is more specific to the joint than just the synovial lining. They're somewhat interchangeable, and I will use all of these terms interchangeably throughout. And then joint ill is where we have massive inflammation of these structures as a result of infection that is spread through the bloodstream. Bacteria travel through the bloodstream, normally seeded through other body systems. And this is one thing that distinguishes septic joints and septic arthritis from in the foal from our adult population, where we more often see that because of a traumatic event or sometimes an iatrogenic event, which means that we have done something that has actually introduced that bacteria. Not as common. When we talk about our foals, it's almost invariably through their bloodstream that this is happening. So how does this occur? Some predisposing factors are going to be failure of passive transfer, respiratory infection, umbilical infection, or gastrointestinal infection and translocation through the gut. And that bacteria is then going to enter the bloodstream and then seed into the synovium, which is the joint lining, seed into the growth plate or the physis, and then the metaphysis and the epiphysis, which is the bone on either side of the growth plate. From there, we're going to have massive inflammation and degradation of that joint environment and a true septic process where bacteria has set up in there and starts to take over that joint environment and destroy all those structures that we talked about. There's generally 2 manifestations of this disease with an age divide around 3 weeks or so. Those foals that are younger than 3 weeks oftentimes have infection in multiple sites, and those infections are typically in the synovial environment, so limited to the joint itself or in the epiphyseal bone, so the bone that sits between the joint and the growth plate. In our older foals, so 3 weeks and older, we're looking at typically only one joint or growth plate infected. And that infection is typically at the level of the growth plate or from the growth plate heading up towards the middle of the bone and away from the joint. These aren't hard and fast rules, but they are generalizations of patterns that are commonly seen. Clinical signs that you may have joint ill include swelling of a joint. So effusion is the veterinary terminology for there being increased fluid inside of the joint itself. So that joint is big, it's turgid. You're also going to have heat, and you're going to have pain on palpation or pain on passive flexion. So if you say have a foal with an effusive or swollen hock and you ask them to flex it, they're going to resent that because there's so much fluid in it. It's really painful for them to do so. Oftentimes they're going to be quite lame, but there are certain sites that don't necessarily make them as lame as you would think that they should be. And a lot of times these foals are going to have fevers as well. So these are all things to watch for in your foal populations. This is just a video exemplifying the degree of lameness that we can see. This is a foal that's in a hospitalized environment, so actually already under treatment, but can see on that left hind limb, which is bandaged, just how sore this foal is and unable to get around. It's quite debilitating. If you see these signs in your foals, prompt veterinary evaluation is really important. It's important that the foal gets assessed because it's going to ultimately affect what the outcome is going to be and what that prognosis is going to be, both for survival and for athletic performance. I'm going to talk about each of these diagnostics here more in depth, but just to run through in general what we're going to do, any foal exam is always going to start with a comprehensive physical exam. So looking at the foal from head to tail, we will get to the joint or the site that's affected, but we need to look at the whole foal and not just the affected joint. We're going to get a sample of that joint, a joint tap, and perform an analysis on the fluid that we obtain from that sample. And we're going to learn a lot from that, both at that time that we're looking at it when we get the sample, and then when we send out for culture and susceptibility as well to find out what might be growing in there. We're going to perform generalized blood work, a CBC and a chemistry likely, and we're also going to measure some inflammatory markers that can help us guide treatment going forward if we repeat those measures and see what the response to treatment is. We're going to perform x-rays of the affected site. We're going to ultrasound likely the affected joint itself, and then also the umbilical structures and the thorax, because like I mentioned earlier on, oftentimes these foals have disease in other systems, and it's important that we're treating everything when we come up with our therapeutic plan for these guys. So starting with that joint tap, this image is actually in an adult, but I think it illustrates well aseptically placing a needle into the joint space here between, this is two bones in the carpus. What we're going to be looking at here initially is what the gross appearance of the joint fluid is. Normal joint fluid is clear to straw colored, and it has a really nice viscosity in it to it. Infected joint fluid does not look like that at all. It can have a variety of different colors. Oftentimes it's bloody, orange, it's cloudy, it's opaque, and it actually loses that viscosity. It's much thinner because of the degradation of that joint fluid by all of the inflammation that's going on from the disease process. We're then going to take that sample to the lab, and we are going to run a bunch of tests. We're going to start with a total nucleated cell count. That's going to tell us how many inflammatory cells are in that joint environment. Normal joint fluid has very few inflammatory cells in it. So anytime that number is increased, there's at least inflammation, if not infection. I'm putting greater than 10 to 30,000 cells per microliter here. I know that's a big range. Some of the context clues with the other things that we're looking at are going to tell us whether or not that is septic. There are different reports that say different cutoffs. So I think it all has to be taken contextually here. We're going to be looking not only at how many cells are there, but also the type of cells. So the neutrophils are the first, or the type of inflammatory cell that are going to show up first for an infection to try and clean up. So they're going to try and eat the bacteria that are in there. So if we have a lot of neutrophils in that joint environment, that's going to be concerning that there's a lot of bacteria causing a lot of inflammation, and the body is sending a lot of neutrophils there to be able to take care of that. And these are two cytology slides here showing both septic joints. Sometimes we're going to see bacteria that's sitting outside of cells and relatively normal looking inflammatory cells. This just looks like mush because there's so much degradation of the cells by the bacteria, which are actually in the cells now. So the cells have tried to consume the bacteria, and all of the toxins in the bacteria are now basically destroying the cells secondarily. We're going to be looking at the total protein. Normally in healthy joint fluid, that's going to be less than 2 to 2.5. So when that's elevated, it's something else that supports that joint could be septic. We're going to take a sample of that joint fluid that we've aspirated, and we're going to put it in a blood culture vial in addition to the foal's blood as well. This is going to give us growth in about 86% of samples in this vial specifically. Some of the common things that we're growing are, I put a list of bacteria here. In general, these are things that are going to be in the environment, things that are going to be in the feces, and things that grow in normal skin as well. We're going to perform radiographs on the affected area or areas. What we are looking for here is there any bone involvement? Foals with septic joints much more commonly have bone involvement than adults because of the nature of the disease. What is important to note, though, is that when the infection shows up, even if there is bone involvement, that bone involvement might not be radiographically apparent or visible on x-rays for up to 21 days after the infection. So not only are we going to take x-rays off the bat, we're likely going to monitor x-rays over the course of the disease. So some of the images here illustrate what we're looking at. This is a hawk, and we're looking at this lateral trochlear ridge and this black area right here, that's showing loss of bone density because of disease. Here we're looking at a medial malleolus and just loss of bone, and then some abnormal bone there. And there's loss of bone density here in this medial femoral condyle as well. This image is taken right out of a recent paper, and it is just a way to show what the changes on x-rays actually translate to when you're looking inside the joint itself. So in the middle, we have an x-ray. This is a slice from a CT, or computed tomography, which is essentially just a three-dimensional x-ray. And then this is a postmortem sample. So here we can see bone loss in this corner on the medial condyle. We can also see that compared to over here where we have nice joint space, there's not as much joint space over here. What the CT shows us is how much of this bone that's right at the joint level, so the subchondral bone, is actually lost. And then when that joint is open post-mortem, there's a huge ulcerative lesion here on the condyle. There's an ulcerative lesion on P1 that matches that. And looking at the nature of the cartilage over here, it's white and shiny. It's all thinned around here as well. So it just tells you what's going on in the joint itself when we see these small changes on x-rays. We'll oftentimes use ultrasound on the joint, on the physis, growth plate, to assess as well. Some of the things that we'll be looking for are inside of the joint capsule. What is the nature of the fluid? So here we're looking at two hips, the left hip being the affected hip, the right hip being normal. This is the joint capsule extending around here versus this joint capsule here. This joint capsule is distended. There's effusion in the joint, and a hip joint is not one that we can see on physical exam that it's necessarily effusive. So this is really helpful. And there's an increased, here we're seeing that the joint fluid is more black. Here there's more gray in here, which is telling us that there's increased cellularity in that joint. This ultrasound is showing a physis. And bone is this bright white line here, but a physis should be a relatively flat line to a relatively flat line with a space in between. Here we actually have this black is actually fluid because there's an abscess here, and this is abnormal bone growth because of the infection that's going on. We're going to transition from diagnostics to treatment. So the tenets of treatment for any kind of joint ill are going to be local lavage and antimicrobial therapy. There are many different manifestations of those two, but those are the two basic things that we need to accomplish. For local lavage, we're typically talking about a needle flush or an arthroscopy in order to flush out all the bacteria and inflammatory mediators in that joint. And for antimicrobial therapy, we're going to break that down into two separate categories. We're going to have systemic antibiotics that we're giving to the foal. Usually those are going to be intravenous off the bat. They may transition to oral, but essentially that's delivering antibiotic to the whole body, versus local antibiotics, which are going to be directly into the area that's affected. When we're admitting a foal and making our initial treatment plan, our systemic antibiotics are typically going to be broad spectrum to start, but we will ultimately make that decision as the treatment plan continues based on culture and sensitivity. And for local antibiotics, For local antibiotics, oftentimes we'll choose an aminoglycoside as our first line of treatment, depending on some other systemic parameters of the foal, if that's appropriate choice. And then again, transition that decision based on culture and susceptibility. This picture here is just of a plate showing the susceptibility patterns. So it's something that we can do in hospital. And what this is showing is just how much bacteria growth is inhibited by these little antibiotic discs. So moving on to the joint flush, the big saying here is dilution is the solution to pollution. So like I mentioned before, we are removing bacteria and inflammatory mediators with this treatment. We are putting usually 2, 3, 4 needles into this joint. We get the sample, and then we are pressurizing fluid bags to run through these different needles. Many joints have different access points in order to flush out the cavity as thoroughly as possible. At the end, we'll leave 1 needle in and we'll deposit antibiotic, bandage the limb, and then that treatment is typically done for that treatment period. Arthroscopy is when we are, I'll back up a second step here. This is typically done under just a brief anesthetic, oftentimes stall side. So the joint itself is sterile, but you're not in the OR for this. This is done routinely stall side. Versus arthroscopy, this is putting the foal in a complete aseptic preparation for the joint that's affected, typically in the operating room. When we're reaching for this is if we're doing our assessment and there are bony abnormalities of the joint off the bat. If you have a foal that's admitted and you've been managing them with the needle lavage and you're just not getting the response that you would hope or expect at that point, if that were truly affected, you may need to go do the arthroscopy. When the condition is chronic, so the foal is coming in and this has been going on for longer than it should have been before evaluation, you almost want to have an idea of going in there with a small camera into the joint to see what's going on, to be more aggressive with the management and probably prognosticate. And when fibrin or debris are present. So fibrin is a byproduct of inflammation and infection that is going to lay down this thick yellow gelatinous surface on the inside of the joint. Needle lavage is probably not going to remove this. We will need to take manual or motorized instrumentation in there in order to manage this. But to explain some of these pictures a little bit better, this is showing that arthroscope or the small camera going in just through a keyhole incision and visualizing that joint surface. And these are some images that camera is taking. This is showing a small abscess on a medial malleolus here. And this is showing an instrument that's able to drop into that and then debride that area away of that infected bone. And like I mentioned, this is an image of fibrin sitting inside of a joint that likely would be not adequately responsive to needle lavage. Another tenet of our treatment is going to be our local antimicrobials. There are many different ways to do this, and it'll depend a little bit of the nuances of the specific disease process that's going on. I've already mentioned intra-articular injection, and that's where we're putting a needle into a joint and injecting antibiotic right in. Oftentimes that's going to be pretty routine following needle lavage itself. A regional limb perfusion is what's pictured here. So we'll isolate a region of the musculoskeletal system with tourniquets, which is going to prevent blood flow back to the center of the body. And we are going to inject an antibiotic here slowly into a vessel, and that antibiotic will perfuse into the local tissues. Here we're isolated in the hock area between these two tourniquets. There's going to be both a concentration and a pressure gradient. For our younger foals specifically, this is shown in an adult here. This will likely be done under a brief anesthetic as well, because keeping them still during this is important to be able to keep these tourniquets relatively effective to get that gradient into the tissues. An intraosseous injection or perfusion. So the perfusion is the same idea as a regional limb perfusion, except that you're infusing right into bone itself with a large bore catheter, versus an intraosseous injection is taking a needle into a bone and depositing antibiotic once, not necessarily under pressure. That's probably most appropriate for our growth plate infections. Following arthroscopy, we can actually leave a small catheter behind in the joint itself, and that'll allow us to deliver repeated antibiotic without having to introduce another needle in, or we can hook up a CRI pump, CRI meaning continuous rate infusion. So there's a constant infusion of antibiotics into that space over time to help with treatment. Physeal debridement, here, this is an instrument, a little curette reaching right into the growth plate itself to debride an abscess that was there. This is something that we need to be judicious about because it's important that we get away any infected bone and are able to clean that out, but we don't want to disrupt growth as well. So this isn't something we're oftentimes reaching for right off the bat. This case was actually that ultrasound image that I showed a few slides back where there was that abscess sitting right at the growth plate. Arthrotomy is the fancy surgical term for putting a larger hole into the joint. So this is going to be much bigger than the small keyhole incision that I had mentioned earlier for arthroscopy. This is truly a salvage procedure. And what you can see in this picture, this is actually a video. It's pretty graphic. I don't know how everyone feels about pus, but essentially there was just such a large volume of very thick pus inside of this joint, and the incision had to be a certain size in order to milk that out. And I do say that this is truly salvage because if the disease has progressed to that point, it's unlikely that that joint environment is going to recover. But this does have a wow factor too, so that's why I included it here. Happy to show that video if anyone wants to see it, but it's a lot to watch. So as much as I like to talk about bones and joints, we need to think about our whole foal here. So these foals are going to be painful on these joints. There's a lot of inflammation going on. So they're going to need to be on anti-inflammatories, likely gastroprotectants, and also probiotics for support while they're on a breadth of antibiotics in the hospital environment. So we've gone through all of the nuts and bolts of all of it, but what does it look like in practice? So what to expect if you have a foal that you suspect may have a septic joint, it's coming into the hospital for evaluation, what can you expect? Like I mentioned to start, we're gonna begin with just a generalized physical exam, make sure to get a sense of if we have any other concerns about other body systems before proceeding with the rest of our plan. Then most of what we're going to do is actually going to be under that brief general anesthetic that we will give just as far as restraint goes and being able to get things done efficiently and effectively for the foal. We're going to collect blood and we're going to perform some of that point of care blood work that I talked about and also get that aseptic sample to send off for blood culture to see if the foal is septic and we do have bacteria running through the bloodstream that could be seeding other areas as well. We're going to get an intravenous catheter into the foal. Then we're going to perform our diagnostic imaging. So x-rays of any clinically affected joints. So whatever they're presenting for. And in our physical exam, we're going to get an idea of are there other areas that may be suspect as well, that while we're doing this, let's image those too. We're going to likely ultrasound the joint, get an idea of what that joint fluid looks like, or get an idea of what that growth plate looks like. And then something else that's really important is that we're ultrasounding our umbilical structures and our thorax as well. Again, we need to think about the whole foal, and these disease processes don't happen in isolation. So we need to see if there's anything else that we need to be concerned of or treat, and also how that's going to affect our prognosis. We're going to get a sample of the joint fluid. The fancy word for that is an arthrocentesis, perform that synovial fluid analysis, and send off a sample for culture. We're going to lavage that joint, still under this brief general anesthetic episode. We're going to choose and make an empirical choice for an antibiotic that we're going to put in that joint, bandage the joint or the limb, depending on the level of what's affected. And then from all of the information that we've gathered from this point to this point, we're going to establish a treatment plan going forward. After the initial treatment, we are going to be monitoring progress over time. So things that we're going to be looking for is the lameness getting better? If the foal had a fever, have the fevers resolved? If the foal did not have a fever, does it have a fever now? We're going to be repeating our x-rays, and we're going to be looking for any bony change. Like I mentioned, there may not be bony change when we're initially evaluating these foals, but there may be over time, and that's going to help guide perhaps a change in treatment plan to something more aggressive and help us prognosticate how good of a job we are doing at tackling this issue. This is, again, another extreme example that I'm showing here, but I think it illustrates a point. These radiographs are taken 5 days apart. And you can see this is the epiphyseal bone, so the bone between the joint and the growth plate. And you can see that there is some it looks a little bit more mosaic-y than it should. But then if you come over here 5 days later, you can see how much bone loss has occurred. So really poor prognostic indicator in this case here, but those radiographs were really helpful in being able to establish that. We'll also be repeating our joint tap and that fluid analysis. We're looking for that total cell count to be coming down from wherever we started. We want to see that come down pretty dramatically. And we also want to see the percentage of neutrophils, which I said those are kind of the red flag inflammatory cell. We want to see that percentage coming down, because what that means is that that joint is starting to recover from the inflammation specifically due to infection. When we're deciding how long to continue treatment, it's really important for us and you all to remember that lameness resolves before infection resolves. So just because the foal is sound and the foal is afebrile, that doesn't mean that we just cut treatment off right there. A little bit of two different scenarios here. When our problem is isolated to the joint itself, so those septic arthritis and synovitis, typically those younger foals, when that repeat joint cytology shows that the total cells have come down and there's less than 80% of those neutrophils in that sample, we're probably going to, around that time, stop the local lavage and local antibiotics. We're going to keep up with our systemic antibiotics for at least 2 weeks beyond the resolution of clinical signs. Oftentimes at that point, it's going to look like, as we have our culture back, we're going to find an appropriate antibiotic that foal oftentimes can go home on if it's stable otherwise. When we're talking about growth plate or bone involvement, so septic fasciitis or osteomyelitis, we are likely going to continue our local antimicrobials for about a week after the resolution of clinical signs, so longer than here. And we're not necessarily getting a joint sample here because joint isn't necessarily involved. Then our systemic antimicrobials, we're going to extend out possibly a little bit longer. So expect 2 to 4 weeks of antimicrobials after all clinical signs have abated. And that's just because the bone infections are just harder to treat, harder for the antibiotics to penetrate, and harder to recover from. So we support them for longer. Sending a foal home from the hospital. This is just a brief overview of what instructions will look like. The foals are going to go home on medications, including antibiotics, an NSAID to help with pain management, oftentimes a probiotic and a gastroprotectant. They're going to be initially stall restricted until we are certain that they're thriving and doing well at home. And we've transitioned down care. They've gone through a clinical recheck before giving the thumbs up for more exercise, because we don't want them to be exercising on a joint that's significantly inflamed. There may be bandaging to do depending on the level of the affected joint. And then usually we're recommending a follow-up examination, either with whoever's seen a primary care veterinarian or follow-up from the hospital itself with a clinical exam, repeat radiographs, either to see if we're seeing improvement where there was a change on the x-rays before, or just to document that there has not been any negative change since the last check. We'll be likely doing some blood work, both to look at CBC for overall systemic health, and then fibrinogen is one of the inflammatory markers that I mentioned as well. We may be ultrasounding the umbilical remnants or the thorax. And again, this is looking at the full foal and was there any evidence of disease there prior. In these discharge statements, we're going to be recommending that you be monitoring for any increased lameness, swelling, heat, difficulty rising, the same things that you were watching for before the foal came up with the septic joint in the first place. Any increased temperature exceeding 101.5, watching their umbilicus for any increased size, drainage, or heat, keeping an eye on their appetite and their urination, and the size and consistency of the mare's udder as well to ensure that they're nursing. I'm going to spend a couple minutes to talk about our prognosis. There are a lot of papers out there with a lot of variable information. I tried to sum that up. Overall, I'm going to say prognosis for survival is good with an asterisk. The asterisk is that we're seeing these foals acutely. So getting to that point where we're diagnosing and managing them pretty quickly after the onset of signs, that they don't have significant comorbidities. And what comorbidities means are disease in other body systems. And the literature that's out there says that 42 to 80% are going to survive. The 42% is typically older papers. They're trending up. The more recent literature is definitely trending up. Things that are going to increase the chance of survival include foals that present with clinical signs that have been going on for less than a day, when we're talking about aggressive and multimodal treatment. And what I mean by that is all the things that I've talked about already, not only doing systemic antibiotics, but doing local antibiotics, doing different modalities of local antibiotics, essentially trying to get after this bacteria as many different ways as we can so that we can get ahead of it. And then there's one report that says that continuous synovial infusion, so that putting that CRI pump in after an arthroscopy is going to increase their chances for survival. Things that are going to decrease their chance of survival are specifically the involvement of the epiphysis, or the bone that sits between the joint and the growth plate itself. That those foals tend to not do as well than foals that just have a septic joint, just have a septic physis. In general, bone involvement tends towards the negative already, but specifically the epiphysis is an area they're going to struggle with, because that's the bone plate that's going to sit underneath the joint as it develops. Multisystemic disease, again, I've already touched on this a few times. So disease in other body systems, if they're septic, if they have pneumonia, if they have septic umbilical structures, if they have a gastrointestinal issues as well, all of those things are going to translate to a worse prognosis. And then specifically if salmonella is the bacteria that is isolated, either in the bloodstream or from joint fluid, those are negative prognostic indicators. When we talk about athleticism, overall, I'd say the reports are more mixed than for survival. Things that are going to influence are ultimately things I've already mentioned here. So the presence of systemic sepsis and multisystem disease, the number of joints that are involved, which is something I haven't really touched on yet. If there's a fewer joints that are involved, typically the better the prognosis. The presence of greater than 95% neutrophils in joint fluid at admission. I've mentioned this a couple of times. Someone doing a paper found this as a cutoff level, saying that if there are more than 95% of these specific type of inflammatory cells in that initial fluid, that is going to be a negative prognostic indicator for athleticism, specifically for thoroughbred racing. Prompt initiation of treatment and the presence of osteomyelitis or bone infection, all of those things are going to affect whether or not, by the literature, these foals are going to go on to race. Specifically, there's some positive news though here. One report that's just isolated to thoroughbred says that there's no difference in the mean sales price, or the percentage of these foals that ultimately get sold at the weanling, yearling, or 2-year-old sales, compared to controls. Whereas another paper says that these foals in general are less likely to start, and it takes them longer to reach the first start, but there isn't too significant of a drop off. So out of a control population, if 66% of thoroughbred foals that don't have disease are going to reach their first start, only 48% of those that have had joint ill are going to get to that point. Another paper that looks at both standardbreds and thoroughbreds together says that 79% survive to discharge, which is quite a good rate to discharge compared to some of the other, the range that I gave earlier, but only a third of those race. So that's a big drop off. And I think what this tells me is that what happened between discharge and the next few weeks at home there makes me question that. So the take home points, I want to reiterate that a lame foal is an absolute emergency and should be seen ASAP to get appropriate treatment started, because ultimately that's going to affect your prognosis both for survival and for athleticism. This is a distinct disease process from septic joints in adults. I mentioned that at the beginning. So we have to think about it differently, and we treat it a little bit differently too. The prognosis is ultimately dependent upon the rapidity of the diagnosis and initiation of appropriate treatment and the presence of any comorbidities, so disease in other body systems. Overall, prognosis good for survival when the infection is limited to just the joint itself, but there's mixed reports for athletic prognosis overall. So here are some references, and with that, I'm happy to entertain any questions.
You mentioned that it takes about 21 days to see bony change.
It can.
Is that the same? Is that for foals or is that for adults?
For foals specifically. For foals, yeah. Adults, it's not. The pattern is just different in adults. Adults, it's much less common to have bony change in adults in general, and that's because of the way that the blood vessels are regressing as foals mature in that very early stage of life. Yeah. Oh, yes. The question was regarding 21 days to be able to see bony changes on x-rays. Yes.
Do you employ the use of stem cell therapy?
Typically not for sepsis, because what I don't want to do is give bacteria another medium to grow upon. I think when we talk about stem cell therapy, there's a lot of, we probably have more questions than answers. And I think stem cells do have their place with joint therapy, but sepsis is probably not a place that I would reach for them, because I would worry that I'm doing more harm than good. What I want to do is really use the tools that I can to get the infection and inflammation under control. And if we have some deterioration of that joint that we know is going to be a chronic problem, then far after the resolution of the infection would be a time that we could consider using stem cells as an adjunctive therapy to maximize that joint's potential and health.
So when a foal presents to you with swollen joints, depending on the age, what do you suspect initially?
It's joint sepsis, no question. Yeah, if a swollen joint in a foal is a septic joint until proven otherwise.
Even in the early stages when they're still
in the early stages, I mean, so you're talking like just after birth?
Yeah.
Just after birth, I think in the first week, you start to get into a gray area. Immediately after birth, there may be a little bit of joint swelling, but at the same time, as soon as that foal is standing, the disease process doesn't happen quite that quickly, because the bacteria has to get in there some way. And ultimately, some of these foals are coming out meconium stained, and they could have had access to bacteria earlier, but I think we're not seeing this immediately after birth. Usually we're at least about a week old when we're going to start seeing these.